We started looking at blood disorders under the circulatory system, and we looked at anemia. Therefore, today we're going to look at bleeding disorders. There are several different types of bleeding disorders. So, first of all, what is coagulation? Coagulation is a process by which blood changes from a liquid to a gel, forming a clot. That clot that will eventually stop the bleeding from continuing. It potentially results in hemostasis, the cessation of blood loss from a damaged vessel, and then there will be repair. The mechanism of coagulation involves activation, adhesion, and aggregation of platelets. So first of all, the platelets are activated, then they start adhering to the endothelium as well as to one another, and then they start aggregating. And then there is deposition of a protein known as fibrin. Now, there are several protein components that are known as clotting factors, which are involved in the blood clotting mechanisms. And these factors are numbered 1 to 12. Each of them has other different names, 1 to 13. So these are the clotting factors. What are bleeding disorders? These are disorders that involve an abnormal tendency to bleed. A normal person will bleed for a certain period of time depending on how big the wound is. But someone who has a bleeding disorder will continue bleeding for much longer. They can be classified into 3 major groups. The disorders of thrombocytes, meaning disorders of platelets. Okay, so these disorders of platelets include thrombocytopenia, thrombocythemia, and thrombosthenia. And then we have bleeding disorders which are due to defects in clotting mechanisms, and these include hemophilia. Now, these ones mostly are due to a deficiency or lack of one or more of the clotting factors that we have talked about. And these include hemophilia, prothrombin deficiency, oral anticoagulant therapy, and another one is advanced hepatic failure. The liver failure will lead to a person having bleeding disorders because the liver is the one that is involved in the production of a lot, if not all, of those bleeding of those clotting factors. So without any of them, it means the patient will be bleeding more than they should. The third group are disorders due to defects of the blood vessels. This is where some components of the blood vessels are not working the way they should. Okay, these can be as a result of conditions such as measles, typhoid fever, okay, and septicemia. Other things may be drugs such as aspirin, furosemide, and methazine. Okay, so let us start looking at these bleeding disorders one by one. First of all, we have thrombocytopenia. We said that this is as a result of lower numbers of platelets, much lower than the normal amount that should be circulating. Now, these platelets, they are destroyed as soon as they are produced or are not being produced at all. Okay? So the normal lifespan of platelets should be about 8 to 10 days. However, in a patient who has thrombocytopenia, you'll find that the platelets will only live about 1 to 3 days, which is a very short period of time. What is the cause? What are the causes of thrombocytopenia? We have decreased platelet production where the platelets are not being produced enough. It could be inherited. It could be someone who has aplastic anemia. This is an anemia where the bone marrow is not producing as many blood cells as it should. Okay, we have hematologic malignant disorders such as leukemia, where there is too much white blood cells, such that the production of other blood cells is suppressed. Okay, we have other things that suppress the bone marrow, such as the drugs, and then we have chronic alcoholism, viral infections also. Then we have deficiencies in some vitamins, such as vitamin B12, also known as cobalamin, and folic acid. And then we have increased platelet destruction. This is the second cause of thrombocytopenia, and this can be due to the increased platelet distribution due to pregnancy, could be infection, could be severe burns, and then we have other things and that cause increased platelet distribution, where the platelets are needed in many, many more places there is need. Okay, so we have immune thrombocytopenic purpura, human immunodeficiency infection, as well as drug-induced thrombocytopenia. And then also splenomegaly, okay? Then we have drugs and spices that cause abnormalities in platelet function. Okay, we have some drugs that cause abnormalities in platelet function, and these abnormalities include one, the suppression of platelet production. Okay, some of the drugs that cause suppression of platelet production includes thiazide diuretics, alcohol, estrogen, and chemotherapeutic drugs. And then we have other drugs that result in abnormal platelet aggregation. These include groups of drugs such as NSAIDs. Under NSAIDs, we have drugs like ibuprofen, indomethacin, and under antibiotics, we have penicillin and cephalosporins. Analgesics, we have aspirin and any aspirin-containing drugs. Then we have spices such as ginger, cumin, turmeric, cloves, and garlic. These also leads to abnormal platelet aggregation. Other drugs include vitamins such as vitamin C and E, drugs such as heparin, okay, chloroquine, digoxin, methyldopa, phenobarbital, quinine, rifampicin. All these drugs have side effects against platelet aggregation. The second group under thrombocyte conditions of thrombocytes is thrombocythemia. This is a non-reactive chronic myeloproliferative disorder in which there is an increase in the number of circulating platelets. This is where the platelets are now in persistent increase. They are high. The number is greater than 450,000, okay, micrograms per liter. All right. The clinical course, it can be complicated by thrombotic or hemorrhagic episodes. The third platelet condition is thrombocythemia. Okay, it is a very rare inherited blood clotting disorder. It is characterized by impaired function of platelets. In here, the platelets are weak, and this one normally starts from birth. Okay, we have von Willebrand disease. Von Willebrand disease is the most common inherited bleeding disorder. Okay, the hallmark of von Willebrand disease is defective platelet adhesion, where the platelets are unable to adhere to one another or to the subendothelial components. And this one is caused by a deficiency of this factor known as the von Willebrand factor. Okay, this factor is a large multimeric glycoprotein that is synthesized, produced, and sold in the bodies of endothelial cells. So you find that if this one is not there in this human being, the platelets will be unable to aggregate and to adhere to the endothelium. What is the clinical presentation of platelet disorders? One, the patient will have epistaxis, that is bleeding from the nose. The patient will be easily bleeding from the mouth. They'll be brushing their teeth, but they'll start bleeding from the gums. Patient will have hemoptysis, that is coughing of blood. Hematemesis, they will be vomiting blood. Hematuria, the patient's urine will be stained with blood. Hematochezia and melena. Okay, metromenorrhagia, often exacerbated by NSAIDs. This is where the patient has an increase in there is high bleeding during menstruation. Okay, bleeding from childbirth may be the first manifestation of a mild bleeding disorder. So in males, excessive bleeding following circumcision is often the initial manifestation of this of the congenital bleeding disorder. What do you do to try and diagnose a bleeding disorder? So there are lab tests, a complete blood count, and peripheral blood smear, where you count all the components, all the formed components of the blood. So the lab professional will examine a slide and look for the size, the shape, number of different types of blood cells and count them. Okay, so that is what is going to happen. Then there will be a test for platelet immunoglobulins. This one will be positive. You can check bleeding time, which will be increased. Primary hemostasis. Bleeding time is performed by measuring the duration required for bleeding to stop from a fresh superficial cut made on the volar surface of the forearm under standard conditions. Bleeding time is prolonged with platelet counts below 75,000 micrograms per liter. To treat to treat a patient with a bleeding disorder, you have to recognize if there is an underlying condition. If there is an underlying condition causing this bleeding disorder, or if there is any drug that they may be taking that may result in them having a bleeding disorder. And then we have other treatments that may involve uh, um, transfusing this patient with platelets or with blood, medications that boost platelet count, okay? And this could be maybe a corticosteroid. So surgery may be performed to remove the spleen because the spleen may be involved in breaking down components of blood clotting, including platelets. So let us look at hemophilia. Okay, these conditions, since we've started looking at now conditions of the clotting factors. The second one, the first one was von Willebrand disease. Now we're looking at hemophilia. Hemophilia A. We have hemophilia A and hemophilia B. So hemophilia A is a factor 8 deficiency. Okay, remember we said we have factors from factor 1 to factor 13. So when the patient doesn't have one of these factors, that means there's going to be a problem in the clotting factors, in the clotting mechanism. So first of all, we have hemophilia A. Okay, this hemophilia A is linked to the X chromosome. It is an X-linked recessive disorder. okay, caused by deficiency of functional plasma clotting factor 8. And this one can be inherited or arise from spontaneous mutation. Now, when you say it is X-linked, remember when for everyone, males have XY chromosomes, females have XX chromosomes. So hemophilia will be on the X chromosome. Okay, hemophilia A will be on the X chromosome and it will affect factor 8. Okay, that means factor 8 is not there in a person who has hemophilia on the next chromosome. The development of inhibitory antibodies to factor 8 can severely complicate the treatment of genetic cases. So rarely, development of antibodies to factor 8 results in acquired hemophilia A. So this is what happens in hemophilia, okay? First of all, we said that it is X-linked. Hemophilia is X-linked. Now remember, for a woman, they have two X chromosomes, and for a man, they have one X chromosome and one Y chromosome. Therefore, since we're saying this is a recessive condition, it's not a dominant condition, it's a recessive condition. It will be on one chromosome. It will be on one X chromosome. So if it is on one X chromosome, a woman who has two X chromosomes, it means that one X chromosome will be normal and the other X chromosome will have the hemophilia A. Okay? Now, we are saying that if this person has on one X chromosome, it means since it is recessive, the disease is not going to show itself. However, the patient will be a carrier. This woman who has two X chromosomes, one X chromosome will have the hemophilia A, while the other one will not have it. Therefore, this woman will be a carrier. So this woman, once she gets married to this normal man who doesn't have any hemophilia on his X chromosome, they're likely to have, if they're going to have four children, they're going to have one of them. If one of them is male, and this male is likely to have hemophilia because there is that X chromosome that is that he's going to inherit from the mother that is going to have the hemophilia A bleeding disorder. Now, because this child has one X chromosome, only one X chromosome and another one Y chromosome, it means that that X chromosome is going to be affected and therefore this person is going to have active disease. Okay? Signs and symptoms will be showing in this person. The daughter, on the other hand, we have a 25% of one of their daughters having the hemophilia A on her X chromosome too, meaning she's also a carrier like the mother. Okay. However, these other two will not carry any hemophilia A. Okay. And then this other example is showing us a situation where this man who has the hemophilia A disease, remember the X chromosome on this man's chromosomes is affected. And so therefore, the person is exhibiting signs and symptoms of hemophilia A. And then he marries this woman who who is a carrier of hemophilia A on her X chromosome. So that means they have a 50% chance of having children with hemophilia. So we find that the first child may not carry because they have inherited. If this child is a female, is a male, they may not carry, okay, because they have inherited the Y chromosome from the father that is not infected and the X chromosome from the mother that is not infected. However, you'll find that the second son is likely to be infected because they will get the either the X chromosome from the mother that is infected or the X chromosome from the father that is infected. And so you find that this child will have active hemophilia A disease. And the same will happen here to the child, the female child. This female child will have two X's. However, one X will be affected because the other X, since they have two X's, the other X will not be affected. Therefore, this child will be a carrier. The fourth child, on the other hand, this is a very, very rare circumstance because it's very rare that two people, one who has hemophilia, a male who has hemophilia, can marry a female who is a carrier. So this is a very rare circumstance where the female can also have, because she may inherit an X chromosome from the father and the X chromosome that is affected from the mother, and this girl will have hemophilia A. What are the symptoms of hemophilia A? The patient will have unexplained bleeding, and this bleeding will be excessive from cuts or injuries, or after surgery, or when they undergo a dental procedure. Okay? The patient may have unusual bleeding after vaccinations. The pain, they'll be experiencing pain, swelling, and tightness in the joints. They will notice blood in stool or in urine. They will have unexplained nosebleeds. The patient, if they're a child, there will be unexplainable irritability. So that is it about hemophilia A. Let us now look at hemophilia B. Hemophilia B is also X-linked. It's also recessive, okay? But this one is as a result in the deficiency of clotting factor 9, okay? Now, spontaneous mutation and acquired immunology processes can result in this disorder as well. All right. So this one affects clotting factor 9. The signs and symptoms of hemophilia B include hemorrhage. Now, this hemorrhage is in two joints. You find that the patient will be bleeding in the joints. The bleeding is painful, and therefore the patient will be in pain all the time. It's going to lead to inflammation of the joint areas, and the patient's joints will be deteriorating. So all the joints will be affected. However, we have major joints such as ankles, the knees, elbows in adolescents, okay, and in adults. Now, this is going to result in permanent deformities. There's going to be misalignment, loss of mobility and extremities, of an equal length. So you find that this patient is going to have all these mobilities. Okay. And so what is the treatment? The main treatment for hemophilia um, is replacement therapy. Okay, where we have concentrates of class factor 8 and factor 9, which will be given to this person through an injection in a vein. Okay, so these infusions will help to replace the clotting factors that are low. And now let's look at prothrombin deficiency. This is a disorder caused by a lack of a protein in the blood, and this protein is called prothrombin. The prothrombin deficiency also runs in families. Both parents must have a gene to pass the disorder onto the child. Okay, family history of bleeding disorder is a risk factor. Now, other causes include lack of vitamin A, vitamin K. Some babies are born with deficiency of vitamin K, severe liver disease, because liver disease produces some of these clotting factors, use of medicines that prevent clotting. Okay, symptoms include abnormal bleeding after childbirth, okay, heavy menstrual bleeding, bleeding after surgery, bleeding after trauma, bruising easily, nosebleeds that do not stop easily. The baby after just being born will have these bleeding tendencies, okay? And when they cut the umbilical cord, the baby will be bleeding. What are the exams and tests that you're going to do? You're going to do factor 2 assay, okay? Partial thromboplastin time, prothrombin time. These are, you take the blood and take to the lab, or you're going to check how long it takes the blood to clot. Okay. So mixing study a special a test to confirm prothrombin deficiency. This is done by lab techs in the lab. You treat prothrombin by giving vitamin K supplements, blood transfusion, complete bed rest for this patient, and then you protect the patient from injury. Okay, so when you want to treat bleeding disorders, you can give prednisolone 20 to 40 milligrams. This will help in the inflammation, especially in conditions that cause inflammation, like hemophilia B. You can give vitamin K 10 milligrams stat, which will help to enhance clotting, ferrous sulfate 200 milligrams TDS, folic acid 5 milligrams once a day. Okay. And then in case there is any infection, obviously you're going to want to treat or to prevent infection by giving antibiotics such as ampicillin, and you prevent giving this human being drugs that will worsen the bleeding. So don't give NSAIDs. Do not give any drugs that will worsen the bleeding. Okay, so that is a short lesson on bleeding disorders.